Okay, thanks everybody for joining. Today is March 6th. It is the STS National Database ACSD monthly webinar. On the call with me from STS, this is Carole Krohn. On the call with me from STS, I have Emily Conrad, Banu Yaxi, Melinda, Addie, Nikki, Paul, and Sydney. Very strong group today. And I see almost about 400 attendees have joined on. So thanks for joining. We are going to get started here. Welcome and updates, STS updates, and then Melinda's going to teach us about cerebral vascular disease. I know you will have questions on the upcoming frailty form, so I'll just give a quick update on that when we get over to our calendar. March's training manual has been posted. Harvest 1 close date was on February 23rd. That data is being prepared to be shipped over to STS and that analytics team. And once it gets over here, it takes about 2 weeks to perform the analysis, do all the quality checks and send it back to IQVIA. So we're probably looking at a posting of maybe about another, maybe April or early May, but usually I'm hoping end of April. I'll provide more of an update as we get closer to that date. The frailty data collection will start on April 1st, and that's, I'm going to go over to this important date so you can see what I have here. March 6th is today. That's our webinar. We have a frailty webinar on March 20th. We plan to have the final data collection form approved by the physician leaders ahead of this call, and we will post it on the website when it becomes available. Melinda is working very diligently on producing a nice training manual. And we have the specifications to share with vendors who are interested and able to build out the specs for sites. We have those just about complete as well. So March 20th will be a webinar. We'll do another follow-up, present the final data collection form. I'll send it over to marketing to get posted on the website. If I'm able to get approval prior to March 20th webinar, I will post it on the website sooner. But we won't be sending out a notification to say it's posted, just plan on March 20th as the date. April 1st is the day we start data collection for the frailty section. I'm going to consider this kind of a soft start. The intent is to give sites an opportunity to put a process in place or to finalize processes that they've started for frailty data collection. Again, it's only like 5 or 6 questions, and then the time to chair rises. Put a process in place because the actual mandatory date for collection will be January 1st, 2025. So you'll have between April and January to get everything up and running, and then it's expected that sites will be collecting this data for all of their cases January 1st. Join that webinar on March 20th. We'll address more questions related to frailty with Dr. Weiler von Balmers. And then April 3rd is our monthly webinar at 2 p.m. Central Time. We have a quality improvement series webinar planned for April 17th. This is at 2 p.m. If we have the Harvest 1 data back, we'll present the outcomes from the national outcomes on ventilator times on April 17th. But it's more likely that we won't be able to present that until May 1st, which is our monthly webinar. Or I'm sorry, May 15th, which is the next quality improvement series webinar. If anybody would like to present on April 17th regarding a quality improvement project that you've done at your hospital on reducing vent times, improving extubation and OR times, or decreasing prolonged ventilation times, please reach out to me and we'd love to have you present this on April 17th. Otherwise, we may use this webinar to go over the frailty data collection form one more time, just to, if we get any additional question or too many questions in on April 1st that we're not able to answer during that time. And since this is the date after go live, first webinar after go live, sorry, second webinar after go live. Oh my goodness. It might be just enough time to give you all an opportunity to start collecting or at least review the forms and then come back with questions if you have them. So April 17th, it's a quality improvement series webinar. If anybody has any quality improvement projects, reach out to me. Otherwise, we may use this just to revisit frailty, since it's a webinar following the start of the frailty project. May 1st is our monthly webinar. May 24th, Harvest 2 closes. May 28th, the opt-out for Harvest 2 ends. Quality improvement series scheduled on May 15th. If I do not have the Harvest 1 data on for the April webinar, I will present it on the May 15th webinar. And then we're going to switch our focus over to blood usage, intra and post-operative blood usage, likely starting in June or July on our quality improvement series. So I will ask that if these have been big state initiatives, if anybody has been part of a state initiative or has implemented blood usage improvement projects, intra or post-operative, please reach out to me. Love to have you present on those topics, and I'll prepare our data so we can meet in June or July to start discussing those. And then January 1st, 2025, I just put this date on here so we wouldn't lose track, is the mandatory date to start collecting the frailty information. Okay, I'm out of breath. Harvest 2024, we're in Harvest 2 now. May 24th is the harvest close date. May 28th is the opt-out date. This will include procedures through March 31st, 2024. And that's it. And now I'm going to hand it over to Melinda. Melinda, do you want me to go through these questions before we?
Yeah, I think we should, and then we can just
Okay.
focus on my questions later.
All right, that's great. So Jody's asking if there's been a decision regarding a virtual option for AQO, and I'll let Emily Conrad take this one.
We're planning to do what we did in 2022 when we had our in-person conference. So we had in person, and then we also had a virtual pass. And the virtual pass will be, we'll put up the pricing for that and our in-person registration soon. But it will include access to the virtual platform, e-posters, PowerPoint slides, on-demand content, and then it'll be the recordings of the presentations that are given in Nashville. So if you get the virtual pass, it'll be a little bit of a delay from the in-person content, probably by about a week for those recordings to be posted, but you will have them and you will be able to have that content for a full year. And then we will probably have another webinar similar to how we did the last 2 years with where we bring the speakers back. So if you're a virtual pass attendee, you'll still have an opportunity to ask questions to our speakers. It'll just be at a later date.
Great, thanks, Emily. Thank you, Emily. Melinda, yep. Karen is saying, Karen Hendrick is saying she sent in an FAQ on January 31st and just want to make sure you received it, and what's the next steps for getting her questions answered.
Well, I looked at the mailbox and I don't see anything from Karen anywhere. I suspect maybe it either got lost in the shuffle. Karen, if you don't hear from me in 3 to 5 days, then it's probably didn't get to the mailbox, because I'm pretty good about getting to the questions unless something disastrous happens to me. So I just resend it in.
Thanks, Melinda, and sorry that happened, Karen. Please see if, Melinda, will you send me that over so I can have our IT team check into it too to see what happened?
Can I send what over to you?
When Karen sends in her question.
Oh, yeah. Okay, great. Okay. Yeah.
Thank you. This is from Peter. Risk-adjusted morbidity data is available for all analytic cases in the longitudinal dashboard, but isn't provided in the risk-adjusted dashboard. Can that be fixed? Let me review that. I thought we provided for cabbage, but we don't have separate models for the other, for morbidity, for the other procedure types. It's a combination mortality morbidity model, Peter. So let me check into that further. If you can send me an email, right now my email is a little backed up, but if you could send me an email, I can have something to review and then get back to you on it. This is from Mary, do we continue to report the walk test results in addition to the chair rises? And yes, please continue to collect the 5-meter walk test if you're collecting those, and in addition to the chair rises. Jenny's asking about the February 21st QI webinar. So let me see what happened, Jenny. I don't know if I sent it over to marketing, it should be posted by now, but let me double check on the status of that for you. When will we have the frailty form? Probably, I would say no later than March 20th, we'll have the frailty form posted. Can you share what vendors have expressed interest in incorporating the frailty data points? Cannot, I don't know, Paul, if you wanted to take that one, if you have anything to add, or I don't think we could.
I've had multiple vendors ask about when the frailty form would be available, but I wouldn't expect them to tell me that they are doing it until we have sent them the specs, which we haven't done yet. So I know some of them have done some of the other supplemental forms. So I would assume that they are likely to do these as well. But I don't have any definitive answer from any vendors about this specific form, and wouldn't expect one at this time. So, and I do, Carol, if I could just also point out, I've had the vendors ask me to remind everybody, in some cases, depending upon the way their software is set up or their security model is set up, some vendors are not in a position to be able to do these. So like, we're hoping that they can. And a lot of vendors have expressed interest in doing that, but give them a break if they can't, because it might be that they just weren't initially set up for handling the way we are handling the supplemental reports. So
Understood, Paul. Thank you. Thanks for that information too. Yep. Has there been a communication to surgeons, hospital staff regarding the frailty requirements? Not yet, Jody. We're finalizing that communication at STS, and we'll hope to get it sent out around that March 20th date. Approximately when will software vendors be able to get some type of technical specs for the frailty so we can ensure our STS customers are ready to go on April 1st? I think that the plan is, Paul, is we have to wait to get the approval from the physicians on the data collection form. That call is happening within the next week. And we hope to have everything final by March 20th, which includes the data specs or software specs. Software specs, Paul's already completed, but the data specs are just, we can't send those out until we make sure there's not going to be any changes. So
exactly. Once they're finalized, it'll go out within a few days. So should be very soon.
Thank you, and thanks, Nicole. Is there going to be a scoring point for the frailty assessment tool that was presented in the previous meeting? So, that is something we'll have to work with our physicians on. Right now, there is no scoring calculator, or the calculation's not going to be provided right up from the get-go, but it's something we'll work towards providing depending on the guidance that we receive from our physician leaders. Can the risk assessment score be done by a nurse? Yes, it could be done by a nurse, Jennifer. And it's not a score, just so we're clear, it's a set of questions that we'll use at STS to determine the score. But it's not, we're not having sites just abstract a score. It'll be a set of questions that need to be completed. Do you know when we will have the final documents and requirements for frailty? Yeah, I would think that by March 20th, we should have those finalized. The same thing with the communications to the data managers and sites. Oops. One of our surgeons at my hospital is saying he attended a meeting where they said there will be a pathway to have patients disqualified from counting them as a complication in our reported STS numbers if their pre-op risk is high enough. Is there any truth to this? I don't know what meeting he attended. Thanks, Dana, for the question. So there's always ongoing discussion about making sure we are, there's always discussion at STS about our risk models and the patients that are included in them. And if there's any way that we can provide a mechanism to exclude the exceptional risk patients. That is a discussion that's happening at STS. There's no information to be shared at this time on it. Once there is, though, of course, we'll bring it to this group and share it with you all regarding that process. What are the ramifications in the event that a patient's frailty score is not completed? Would that patient simply not be risk adjusted? Great question, Neil. So right now there is, at the start of this data collection, there is no required threshold. There are talks about adding in required thresholds for sites to meet to be included in analysis similar to the mortality thresholds that are currently implemented. So more information will come on that. And we might even have more information on the March 20th webinar. All right, Melinda, I'm trying to get through the questions, but they keep coming in. If our third-party vendor has the info for, and that's fine, I appreciate the questions. I just want to make sure we have enough time for Melinda's education. So I have one question from Hannah. When I get to Hannah's question, that'll be the last one I take, and then we're going to hand it over to Melinda for the education. If our third-party vendor has the info for us to collect a frailty there, do we still have to put it in red cap? Nope, just collect it in one. Just use your vendor's information to collect it within there. When will the info on the AQO be available? My hospital is asking about the cost. Emily, you have anything on that?
I would say mid-March, mid to late March, we'll put something on the website. We're discussing that internally right now.
Thank you. If there is no score available to the site, then how is this something useful for providers? So that's what we're working on, how that is going to be provided back to providers so it is useful. To start with, it's likely that this will be included in our risk calculator. So that will be useful in shared decision making when we have enough data to incorporate that into the risk models. And then there's, of course, decisions we're talking about, different patient reported outcomes and things like that. That'll be helpful. So more to come on that. We don't have all the final decisions made. Can a physical therapist perform the chair rise assessment? Yes. Physical therapy can perform the chair rise assessment for the patient. And then Hannah, why is STS using a red cap instead of updating the STS program? Yeah, and there's limitations about correcting errors and things like that. So Paul, so to start with, the reason why we're not, we didn't do an upgrade just for frailty is because we didn't want to do an upgrade just for frailty. Frailty are very resource intensive for the STS, costs us and sites to lots of changes to the database. We have to be aware of when we're looking at performing analytics and things like that. And we just brought all the analytics in-house, so our research and analytics center is getting settled with the current versions. However, this is something that would be added, frailty would be added into a new version if we have a version upgrade, which one is not planned at this time. Because they're pretty happy, the surgeons are pretty happy with the version 4.2 and what we're collecting there. The beta blocker form is only running for a year, so there was no need to put that into a version, because once you put it into a version, you can't really take it out, and we didn't want to cause sites extra burden with collecting the data longer than what's necessary for that project. Frailty is a little bit different, but we will be adding it into a version upgrade when that time comes, but no time is planned right now for that. Good question, Hannah. Okay. Melinda, I'm going to hand it over to you. There's 2 other questions, but we can get to those after your presentation. I just want to make sure you have enough time.
Okay, well, we are doing cerebral vascular disease this month. We haven't done a risk factor webinar in quite some time because we've had all these special projects going on. But so this is actually the last section in the risk factor. So we're going to go through it, and we are going to have some Q&A and see how you guys do with it. So when you look at the cerebral vascular risk factors, when we're talking about CVA, CVA-WIN, do they have a TIA? Do they have carotid stenosis? Have they had prior carotid surgery? All of those things are in the risk model. And then all of those things that we just said were also audit fields in the 2023 audit. So, and the thing about risk factors is the risk factors that especially play into the risk models, generally speaking, are make up a large portion of your audit fields. So that's why we're going over things like this, to make sure that everybody's on the same page when you're coding these. Next slide, please. Okay, so let's just first kind of go over this definition really quickly, and then we'll get into the questions. So when we talk about cerebral vascular disease, which is sequence 525, the first thing that we are to do is to indicate whether the patient has a current or previous history of any one of the following. So stroke, TIA, a non-invasive or an invasive arterial imaging test demonstrating equal to or greater than 50% stenosis of any of the major extracranial or intracranial vessels to the brain. You can also have vertebral artery disease or internal carotid disease or intracranial disease equal to or greater than 50% stenosis. We do not capture external carotid disease. That's excluded. The other thing that plays into cerebral vascular disease is previous cervical or cerebral artery revascularization or a percutaneous intervention on the cerebral artery. If you've had a brain or cerebral aneurysm, that can also be captured as cerebral vascular disease. And occlusion of the vertebral artery, the internal carotid artery, and the intracranial arteries due to dissection. So there are some cases that come in with a dissection, and the occlusion is occluding one of their carotids, their internal carotids, so that can also be captured. So I wanted to just kind of get those out there before we start the questions, because it's quite a definition. So let's go to the first question. I think that, okay, so this is question number 1. Get your fingers ready for polling. Would vascular dementia be coded as yes to CV disease? A is yes, B is no.
All right, and we have a new polling engineer, Emily Conrad. There you go, Emily.
Oh boy.
You did
Hang in
it.
there. Hang in there.
Did you like that polling engineer? This is a tricky one, Melinda. It's probably right in the definition you just provided.
Well, it looks like 80, 85, yeah, 85% say no. Okay, I think we're good. So 86% of the people said no, which is the correct answer. So let's talk a little bit about that. Next slide, please. So the answer is no. So when you look at the qualifiers that we just went over for what constitutes cerebral vascular disease, this patient here has vascular dementia. So what does that mean? Probably has lack of blood flow to his brain, but you don't have any of the qualifiers. You know, this is all you know. You don't know if his carotids are occluded or if his vertebrals occluded. You don't really have no history of a stroke. So just taking this at face value, you can't code it as yes, because you have to have one of those qualifiers in the definition that we went over on the previous slide. So it's kind of tricky, but I just wanted to point that out. All right, next slide. Okay, question number 2. The patient has a history of subdural hematoma. Would I code yes to CVD? A is yes, B is no.
Emily's on it with that polling question. It was
She
like right when you
is.
said that.
The new polling engineer.
You guys are too kind.
All right, we're about 80-20 here.
Yeah, this was in the, I think, I know the answer to this one. I'm not saying anything. Keep my mouth
Okay.
shut.
I think we're, well, I think we're pretty good. We're like at 80-20 split, so we'll stop. And so almost 80% of you said the answer was no, and the answer is no. So subdural hematoma, or an AVM, is not coded as cerebral vascular disease per the training manual. Again, it's not really an intracranial vessel, and it's not really a stroke. It's not really a TIA. So we do have specific instructions about that particular entity, and we would not code it. All right, next question. Question number 3. During the pre-op workup, the carotid duplex ultrasound revealed an occluded right vertebral artery. Can I code this as cerebral vascular disease? A is yes, B is no. Oh, they're on there. All right, let's see who was listening in the first. Let's see who was listening to the beginning of my presentation.
I would have just took a screenshot of that first one and just had it up on my screen as you went through these questions.
I probably should have, but I know they've got their training manuals open right now, and they're looking for the answers. Okay. 80-20. 80. Gosh, we got a lot of 80-20s going on.
I think can you move the polling on the panelist side? Can you move the polling screen yourself?
Can I? No. Well,
no,
I can.
I mean, I can move my polling screen. I wonder if the attendees can move it.
I can move my polling screen, so you might be able to move it.
Okay, I'm going to go to the answer. Ready?
Yep. And the answer is yes. So, and 80% of the people said the answer was yes, so that's great. Vertebral artery disease, if it's equal to or greater than 50% stenosis, can be coded as yes to sequence 525. That's the only place you code it, though. So you code it as sequence 525, and then all the child fields under 525, you just code no, because it's not carotid disease, it's vertebral disease. Okay. Question number 4. My patient has a 60% stenosis in the carotid bulb. Can I code CVD? A is yes, B is no. They're probably looking up anatomy right now.
I know they are.
Yeah.
I know they are.
What is the carotid bulb? Where is it at?
Google's like, why are 400 people searching carotid bulb?
And I don't make these questions up. You guys send me these questions, okay?
Uh-oh, Melinda, you got another one.
80-20. Wow. Okay. I think people are still, yep, here we go. We're still about 80-20.
Yeah.
Okay. Guess we can stop. Okay, so 76% of you said yes, and the answer is yes. So just so you know, the carotid sinus is also known as the carotid bulb. And it's a neurovascular structure that appears at the bifurcation of the common carotid artery and the beginning of the internal carotid artery. So it's basically the beginning of the internal carotid artery. So yes, you can code for a carotid bulb stenosis of 60%.
Do you want me to Google and show a picture of it?
If you like. I should have had a picture here or something.
Yeah, because I think this is really, it's this. Let's see if we can find a good one.
You might have
Right
to,
here, right?
yeah, you might have to,
Here.
there it is, the carotid bulb. Yeah, so see how it's sort of the bifurcation. So if it's in the carotid bulb, then it's affecting the internal carotid flow. So you can code that as yes.
All right.
All right, number 5. Okay, head CT was done 2 days post-op on a cabbage patient. The CT report showed a chronic linacular infarction. Can I code CVD with prior CVA in this patient? Yes or no?
And KKO 9879, this is for you.
Uh-huh, I know. So I saw somebody ask me that question already.
Uh-huh.
Ah, a little more interesting this time. Looks,
And we've taught on this before.
Uh-huh.
Uh-huh. Well, I can't wait to hear the answer, Melinda. Pins and needles.
Yeah. Think, let's see. Well, what about a 60-40 split? I'm surprised. I'm actually a little surprised at this one. Okay, let's stop it. We're at 60-40. Okay, so the answer is yes. And 60% of you said the answer was yes. So in the training manual, we have instructions that a CT scan following surgery with evidence of an old infarct or a chronic infarct could be coded as yes. So this patient has a chronic infarct on a CT that was done post-op, and we have instructions that you can code this as a pre-op, basically that they have had a pre-op stroke in this situation because it's an old chronic infarct that they found on the head CT post-op. Okay. Question number 6. Oh, this one's going to be tricky. My patient has a history of subarachnoid hemorrhage. Do I code this as CVD? A is yes, B is no.
Yep. That's a good one for sure.
It is. I just got a question about this the other day, too. $70.30. Okay, I think we're staying at around 70-30 split here. So the answer to this question is no. And the reason it's no is because not all subarachnoid hemorrhages will create a stroke. So if you've had a subarachnoid hemorrhage, you may or may not have had a stroke associated with it. So there has to be some form of deficit, whether you have symptoms that lasted longer than 24 hours, like you can't move your arm now, or you've got some imaging that says, yeah, there's an infarct that's happened here. So you just because they've had a subarachnoid hemorrhage, they may or may not have had a stroke. So just kind of dig a little deeper and see if in fact the patient had a stroke, if you see a history of subarachnoid hemorrhage. Okay. All right. Question number 7. Aortic dissection patient. The pre-op CT shows the innominate and the left carotid are dissected and occluded. Can I code carotid stenosis in this patient? Yes or no? 80/20 so far. Up 75/25.
Is this what you were expecting, Melinda?
Well,
That's why we're educating on them, right?
mm-hmm. Yeah. Okay. So we're 80/20. Got a lot of 80/20s going on this call.
Mhm.
Okay. Well, 75/25 now. I think we could stop. So 75% of the people said yes, and the answer is yes. So this was an update in the training manual. I don't remember when, but it's been a while. But if the dissection occludes the artery, then you can code it as 100%. And you can see that when you looked at this CT scan, the carotid, the left carotid, that's the key here. Okay. The left carotid was dissected and occluded. In the surgeons, the way the surgeons described this when we talked about it is that, in a dissection, basically the blood flow is null. So a dissection acts like an occlusion. And these are typically your patients that you guys send me those really hard stroke questions on, because it's really kind of hard to tell if, since this carotid was occluded pre-op, did they have a stroke pre-op or did they have a stroke post-op? Or, I mean, these are the really kind of tricky ones because you've got this carotid artery that's involved in the dissection. And quite often the patient will stroke as a result of that because they don't have any blood flow coming up there. So we definitely want to capture this as a risk factor. All right, question number 8. Okay, patient had a CABG on 12/23. The bilateral ultrasound, the carotid Doppler, was completed on 12/29 and showed a 50 to 69% stenosis in the left internal carotid artery. Can this post-op study be used to code sequence 525 for this carotid stenosis? Okay, we're talking about carotid stenosis, post-op carotid ultrasound. Oh, that's 80/20. 80/20. All right, that's a pretty good split. 80/20. It's about where we've been out all days. And the answer to this question is no. Okay, so let's talk about this because it's a little different than the pre-op stroke that we just talked about, 4 or 5 slides earlier. So this is a carotid study, and it's showing stenosis in the left carotid. So we have a clear instruction that this time frame is the study closest and prior to OR entry, done within 1 year of the OR date. Because, sometimes things can get, emboli could get thrown or plaques could get shifted or things like that. And so this is why we don't allow this particular carotid stenosis to be coded on post-op testing. Okay, so this one's a little different, and I did want to point that out. It is different from an old stroke. So that's the key thing to remember there. All right, question number 9. Can I use the ratio to count this as carotid stenosis? So here's what the report says. Velocities suggest 1 to 49% stenosis of the right internal carotid artery. The ICA-CCA ratio of 2.06 is suggestive of a 50 to 69% stenosis of the right internal carotid artery. So the question is, can I use that ratio impression to code this as carotid stenosis? Yes or no? About a 60-40 here. I think we're going to be, well, 65-35. This was the tricky one. Okay, I think we can stop. 65% of the people said yes. And the answer is yes. So we had an update September of 2021 that if you happen to have a carotid ultrasound that has results reported in both the velocity and the ratio measurements, because sometimes you do, then you can code the measurement that has the highest degree of stenosis. So in this particular example, you'll see that the velocity does not suggest greater than 50. The ratio does. So you can take the ratio and code the stenosis of the carotid based on that ratio in this particular situation, because you have both the velocity and the ratio on the same study that was closest to the OR. Okay. Next question. All right. Carotid ultrasound prior to the left carotid endarterectomy. So prior to the patient having a left carotid endarterectomy, the luminal diameter of the proximal right internal carotid artery is 70%, and the left carotid artery is 81%. The patient has a left carotid endarterectomy on 117, which is prior to his CABG on 119. Should sequence 545 be coded as right or both? So basically the question here is, do you have right carotid stenosis prior to the CABG, or do you have both right and left stenosis prior to the CABG?
Going in for the cabbage, right?
Going in for the CABG.
Going in for the cabbage.
Hmm.
That's a tricky one.
I know.
But it happens, right? I'm sure this is very common practice to take care of somebody's carotid and then take them for cabbage.
It does happen.
Mm-hmm.
Mm-hmm. 50, about 50, 60, 40. I knew this one. I get this question a lot.
Yeah. Tricky, Melinda. Always trying to stump our friends.
Okay, I think we're going to stop. We're at 60, 40. And so 60% of the people said just right. And that is the answer. Because the way you need to think about this is, what is the stenosis of that left carotid prior to the CABG, like going into that CABG? So they did a carotid on 117. So they opened that carotid up. That carotid was done. It was cleaned up before the CABG. So the only thing that this patient's going into surgery with is the right carotid being stenosed 70%. So we would only code the right carotid stenosis in this situation, because the left had been corrected by the carotid endarterectomy that was performed 2 days before surgery. Okay. Question number 11. My patient has a history of internal carotid artery aneurysm : do I capture this as previous carotid artery surgery? Yes or no? Well, this was an easy, see this one, 80-20, 80-20. We're at 80-20 all day long almost.
I don't know, because I haven't abstracted a case yet like this, so I don't know the answer. I can't wait to see.
$75, $25. I think that's
Melinda,
probably.
what is a carotid artery aneurysm coiling?
They go in there and I think they open it up a little bit with some coals, but I don't know technically. That's probably not a very technical description of what it is.
No, I think they
Exactly.
use that term in their charting.
Yeah, they
No?
go in there, they take coals and fix it somehow.
I'm gonna Google it.
I just don't know exactly the technical term for what they do. But anyway, so we got a 75-25, about 75-25 split, and the answer here is yes. So there is language in the training manual that says if you have had internal carotid artery aneurysm coils or a history of a carotid angioplasty, that you can capture this as previous carotid artery surgery. Carole, did you Google that? Do you know exactly what they do with that?
Yeah, it's hard to tell, and I'm sure somebody already knows this better. See if I can figure it out. Hold on.
I mean, you see how the flow's better. So they go in there and do something to make the flow better.
Yeah, you can see here that that's where but it's just because it's kinked and then they straighten it out, or is
Yeah.
it because there's yeah.
I mean, you can see clearly that, so the flow is better after the
I'm
coiling.
sure somebody will put it in our chat. Oh, here, I knew Sherry. All right, thanks, Sherry. Aneurysm coiling will plug the aneurysm and seal it off so blood flow is diverted through the normal vessel pathway instead of filling the aneurysm to promote the patient from hemorrhage.
Perfect.
Protect, not promote. Not promote. It'll protect the patient from hemorrhage. Thanks, Sherry.
So
And the other
Thank
Sherry
you,
says they use percutaneous approach to fill the pouch of the aneurysm wire coil. Thanks, the other Sherry. Okay.
There's a lot of people that know all about this. I just knew
Yeah,
it made
I
just knew it made the blood flow better, right?
Yep. Thanks, Deborah. Yeah. Thanks, Jennifer. And thanks, Nicole.
Oh,
We learned
okay.
something from everybody that we work with, Melinda.
I think we have one more question, maybe, or that might have been the last one. I don't remember exactly. Do I have another question, Emily, or is that it?
Looks like you had 13 total.
Okay.
Oh, sorry, I'm slow. I was busy over here.
Okay.
Sorry.
Question number 12. Past surgical history. Carotid artery, subclavian artery bypass graft for subclavian artery stenosis. Is this coded as CVD or PVD? So you've had a carotid artery, subclavian artery bypass graft for subclavian artery stenosis. Is this PVD or CVD?
You're tricky, Melinda.
I don't make these questions
tricky.
up. I really don't. These. Well, 70, 75, 25. I suspected that answer, honestly, because I get this question a lot. And the answer to this question is PVD. Okay, because when you read this surgery that they did a carotid artery, subclavian artery bypass for subclavian artery stenosis. So the bypass was done for subclavian artery stenosis, which would be coded as PVD in sequence 505. It wasn't done because you had a carotid issue. You had a subclavian issue. So, okay. Number 13.
I think this
Patient
is the
has a-
last one, right?
Yes, this is the last one. Patient has a history of prior left vertebral artery occlusion with distal reconstruction. Can I code prior carotid artery surgery? So this is a vertebral artery occlusion and they reconstructed it. Can we code this as carotid artery surgery? 50-50. Huh. I'm a little surprised at this.
I think that's about as good as it's gonna get.
I think so. And the answer here is no. Okay, so this is, remember, this is vertebral occlusions, which you can code in 525 under CVD, you can, but you can't code it as a prior carotid surgery because you didn't operate on the carotids, you operated on the vertebral arteries. Okay, I guess that's it. Good questions from
Yeah, good
everybody.
questions. We have 2 hand raised and 14 questions.
Okay,
Let's go, 3 hand raised. Amanda, are you there? Go ahead and unmute yourself if you want to talk. Dee and Susan, you're able to unmute, go ahead. And I'm gonna go over to the questions. Oh, go ahead, Susan. Okay. All right, ready, Melinda? I'm gonna
Yeah.
do these first 3 real quick, hold on. If we started the beta blocker collection on RedCap and now our vendor has it, do we go back and enter the data in the vendor software or just leave it as it is? You don't have to re-enter the data if you already entered it into RedCap. Just continue forward with entering it into your vendor software. To clarify, the chair raises are to be done before OR, not PT after OR. That's right, it should be done, they need to be performed before going into the OR. Will the frailty questions be added to the IQVIA direct data entry form prior to the 1/1/25 mandatory go live? No, IQVIA is not going to build out this form for us as a supplemental form. It will be included when we do an upgrade. None is planned at this time, but we will include it in the IQVIA platform when an official version upgrade is done for the adult cardiac database. Okay, Melinda, ready? What about history of internal carotid dissection causing partial internal carotid blockage as the opposed to the definition, which is looking at total occlusion?
Well, partial, I guess you have to define what partial means. Is it 50%? Is it greater than 50%? I mean,
I think you would code it according to whatever that partial blockage is
yeah.
then. Yeah.
I mean, yeah, because I think I'd have to ask the surgeon about that because partial depends on how you look at partial. Is partial 50 or greater, or is partial, less than 50? So just I'd clarify that with that kind of documentation.
Thank you. When will this is from Hannah, when will the final frailty data collection forms be posted?
I can answer that.
Hold on. Because of this delay, we will not be collecting this at this time because until we have a final posted document, we cannot start to build into Epic. That's right, Hannah, and thank you for pointing that out. The forms, as I stated earlier, will be posted on by March 20th. And we will be going live April 1st with a kind of a soft launch, and the mandatory start date for this will be January 1st, 2025. So you'll have 8 months to build this into Epic before it's mandatory. Erica, the audit company did not take chronic infarct on post-op CT to count as previous stroke. They should have, Erica, and I don't know if you did the post-audit review with them or pointed this out to them, but could you please email me that information when, I'm not sure if your audit was this year or last year, and if you reviewed it with them and they still did not take it, because we are planning our audit for 2024, and I'll bring this up to them during that time. With the old chronic infarct, what would you code as the time frame?
Greater than 30, I guess. Is there, I don't remember the exact time frame. Let me look at the data collection form. Whatever the old one is. Oh, greater than 30. Because it's old, it's chronic, sort of like an old MI. It's greater than 30.
Okay. And that's the same, this next question from Chelsea. What time frame do you use for CT MRI that shows chronic, I could never say that word.
I know, lunicular. I think that's, I have a hard time with
Lunicular,
it
I always want to say lunar infarct. CVD, CVD pre-op. Some of our patients have lengthy stays and can be in hospital for several months. How do we decide on these patients, or how should we, or should we just assume it was present on arrival at the hospital regardless of time frame?
We have said if you have old or chronic documented, just to code it as greater than 30 days.
Thank you, Melinda. I'm just gonna call it lunar again. Would the chronic lunar infarct be, and somebody's gonna need to send that to me in phonics so I can see, yeah.
I think it's one of those hard ones.
Black
It's
mirror,
30
black
days.
mirror.
It's 30 days.
Okay,
If it's old, if it's chronic, it's 30 days, greater than 30.
thank you. I would count that as an acute event, not as chronic disease. Question 7. Let's see what that is.
Question 7. What is question 7? Okay, so I'm trying to figure out.
Or maybe this was not the right one.
No, she says question 7, so she's carotid. So I don't know about acute. What does she mean acute? I would count not. Valerie, can you? I don't know what she's talking about.
Okay, she'll put it, help us with that one, Valerie, provide us some clarification. I thought we couldn't code the word suggested from question 9.
Well, okay, so I don't really like to get into semantics, but this is a study versus like possible pneumonia, possible MI. Yeah, we don't really do that. But this provider is saying, okay, based on this ratio, this is telling me that the stenosis is 50 to 69%. So this is the interpretation of this ratio that he has obtained from the study. So to me, this is quite
good.
Yeah, this is quite different than possible pneumonia. I mean, this provider's looking at the study and he says, hey, this ratio tells me or suggests to me that this is stenosis.
And that's his interpretation of it.
Yeah.
Okay. All right, Melinda, here we go. Question 6, they didn't really like.
I know, and
it wasn't a big hit with everybody.
No.
You want to go talk about it?
I'll talk about it. So this came directly from surgeon leadership many years ago when we had questions about subarachnoid hemorrhages. And I was told by surgeon leadership that not all subarachnoid hemorrhages are going to cause a stroke. You may have a small subarachnoid hemorrhage that Does not cause a stroke. There's no deficit, and it resolves. And so that is where the language came from. And I think that, as Erica says, if you've got a pretty, if you've got a big subarachnoid hemorrhage, you're probably most likely going to have symptoms of a stroke. I mean, subarachnoid hemorrhages can be devastating in some patients, and in others, it could be a very small bleed. So I think you have to look at the symptoms and your patient's functional status after the subarachnoid hemorrhage and the documentation that's associated with the hemorrhage, because we have hemorrhages of varying degrees. And that is how surgeon leadership has instructed us to approach those hemorrhages based on the varying degrees of hemorrhage and symptoms that occur, because there can be a wide variety in subarachnoid hemorrhages.
Thanks, Melinda. I remember that conversation just exactly as you talked about it.
Yeah. All right.
And I think the part of having the deficit is important here, right?
Yeah. Yeah. And like I said, a lot of times you are going to have a stroke with a subarachnoid hemorrhage, but not 100% of the time. So we didn't want to have a blanket statement that says, hey, if you had a subarachnoid hemorrhage, you definitely had a stroke, because sometimes you don't. So just look at the patient and look at the situation. And I tell people this all the time, this is not always black and white. What we do, you guys do every day. Sometimes there's a lot of gray here, and we all do the best we can in those gray zones.
Yes, ma'am. Okay. All right, okay. So this person sent in a question and then they sent in another one they clarified. Would a brain aneurysm clipping of a lacked MCA aneurysm be counted as CVD?
Well, they had a brain aneurysm, so you're definitely going to code that for sure in sequence 525, because they've got a history of the brain aneurysm. Now, the clipping would not be coded as a prior carotid surgery, but you would definitely capture the history of the aneurysm in sequence 525.
Thank you, Melinda. And that's asking if she could start the beta blocker form now, or does she need to go back and capture earlier cases? And you could start it now, just going forward, collect all of your cases so we can have a good count from your site for all of your isolated cabbage cases. Unless you want to go back, you of course could always go back and enter those, but if you're only able to go forward, that's fine too. For the unable to assess option for the chair rises, patient of the CCU, is it correct to say this would add to the risk adjustment of the case? Yeah, I don't know for sure how the risk adjustment's going to look, because we have to still get the data in before they can make the assessment on what's used. The patients in the CCU, is that like CVICU, Melinda? That's not the pulmonary care unit. It's not the cath lab.
Right. And the other
Okay.
thing is, I'm not sure what form that you're looking at. But on the greatest form that we haven't finalized yet, we've actually got 2 unable to assess sections now. One is due to physical condition, and the other is due to a non physical conditions. such as like staffing and stuff. So we really can't address your question right now because we don't know how any of that's going to play in now.
Thanks, Melinda. Is the Epic Smart phrase used by the surgeon who spoke in the webinar on the new frailty measurement available? Not at this time. Hopefully, March or when we get ready to go live with the version or with the data collection, we'll have it available. I think he was going to put a packet together for sites to be sent out, which that was one of the things that was going to be included or at least made available to sites. So we haven't forgotten about it. It's just not available right now. Lacunar.
Then we got Lucanar. Oh.
Thank you, everybody. It's terrible. I have a hard time sometimes saying words, not lying. A patient can need an operation with subarachnoid hemorrhage.
That's true, they can. Mhm.
All right, follow-up question. Erica says she's sorry, but she's not really sorry. Just kidding, Erica. Follow-up question regarding SAH. No, so a small SAH due to an aneurysm rupture without symptoms should not be considered a stroke, but a small infarct without symptoms should be considered a stroke. Yeah, these are frustrating and feedback we get from providers.
Well, I mean, is your provider telling you the patient had a stroke? Would be my first question. I mean, because I don't, or is the provider not saying? I mean, you know what I'm saying, Erica? You have to like, I can't define a stroke based on the diagnosis of a hemorrhage right now. We don't have that language in the training manual. But if your provider is telling you, yep, this patient had a hemorrhage and he has a stroke, then he's had a stroke.
They listen to document it.
So we can take this back to the surgeons again and see if we have any update. But right now, and this has been going on for quite some time, that we've had that language in the training manual.
Yeah, we can definitely review it with at the core group. The surgeons on the core group and see if there's anything that they want to change or if they're okay with it. Maybe just something we can clarify further. Okay. Clarifying. Yes, for question 7. This is Valerie. Hold on. Since the dissection is an acute event, I would not code it as carotid disease before you clarify.
Right, but we have special language in the training manual in this particular situation that the surgeons have given us permission, even in this acute event.
Because we don't want to leave this out. This is a
it.
pretty important event for the patient, right?
It is. And like I said, quite often, if they've got their carotids dissected and included, they're probably going to have a post-op stroke. So it's nice to, or they might even have a perioperative stroke. It's nice to have that risk factor identified, these patients. So that's why we did that, Valerie.
Okay, thanks, Melinda. Okay, this is from Tracy. I'm going to preface this by saying her doctors thinks this was this syncope was actually a seizure. I had a patient with a syncopal episode which led to admission. On the day of discharge, patient was being wheeled out to the car and was not to have a seizure. In response to this, an MRI was done. Oh, patient must have had, I'm sorry, Tracy, I'm not reading that right, but a patient maybe had a seizure, what they thought was a seizure. In response to this, an MRI was done and showed an acute CVA with no deficits. MD documented that the patient actually had a CVA on admission and not post. So I coded this as a less than 30-day CVA on the risk-adjusted area. Is this coded correctly? I think you're going to have to reach out to Melinda.
Yeah, I'm kind of, I'm sorry, Tracy, I'm confused about the timing of this event. And so can you just send me that question? We can work through it together in the mailbox.
Yeah, thank you. Great question. And then Darlene saying just worth considering regarding the SAH discussion that these instructions are for how data managers should code based on documentation available. And it's not trying to inform clinical practice or diagnosis. Thanks, Darlene. That's a good clarifying point. And Valerie said, thank you, Melinda. All right, are we good?
I think so. I think so. I hope I didn't confuse people more than I clarified. So
Melinda, you do a great job with education. I think you're a little hard on yourself when you say that. Look at that. See, somebody's laughing at you. They're like, Melinda, come on.
I guess the next thing we'll move into is what's this next section in our data collection form?
Let's pull it up real fast and see. And I know we're at time or overtime.
Previous cardiac interventions. That's where we're going next.
Ooh, that'll be a good one. Don't you think? And we're having fun with that.
We will.
Okay, and then also don't forget to reach out to me if anybody has any blood usage QI projects they did at their hospital. Reach out to me because I can get you scheduled for our upcoming new QI series. So thanks, everybody. Melinda, thank you. Great job. Don't be hard on yourself. I think awesome.
Judy said we do need education. I liked that.
Great job, Belinda, as always. And thank you so much, everybody, for joining. And I hope you have a great rest of the day and take care. Thanks, Belinda.